Hello, everybody. Welcome to the Very Connected podcast. And today we're being joined by a lovely person, a lovely friend, Dr. Shannon McMann. Say hello. And she's taking time out of her busy schedule, guys. This she said today has just been crazy. But I'm gonna do like a little introduction before we kind of get started of her background and all of that. I just feel so incredibly fortunate to have you here on this call. Thanksgiving week is a time to be thankful. So I'm just going to say I'm super thankful for you. And our topic today is weight loss medications and management of obesity. And we're going to be talking about tips on weight loss and maintenance. And Dr. Shannon McMann is dually board certified in both internal medicine and obesity medicine, and additionally, and in the process of getting an extra board certification in lifestyle medicine, if she hasn't already, because I know it's been a little while since we've kind of talked. And she works at a teaching clinic where she trains medical students and internal medicine residents in Clinton Township, Michigan. She did her undergraduate and medical school training at Michigan State University. She completed a residency in 2002 at Mount Clemens General Hospital, now Macomb Regional Medical Center. And she's not only a spokesman, guys, she is actually a bariatric patient. And her colleague, Dr. Pesta, which some of you may know, he's really a big part of the bariatric community. He performed her gastric bypass surgery in February of 2020, and she has successfully lost 90% of her excess body weight. And just really, we were talking right before this call, has just really become a part of these communities. I know recently just got to spend some time with her. She attended the conference, the uh, Bariatric Society conference in San Diego. And I also got to spend time at the ASMBS conference. She was there as well. So at this point, Shannon, I don't feel like I'm doing you justice. Just say hello. Tell us even more about yourself. If anybody is here joining us on the live event, please in the comment section, tell us a little bit about yourselves. Let us know where you're from, if you're pre-op, if you're post-op, if you've met Dr. McMahon before, any of that. Okay, go on. Dr.
Hello,
McMahon.
everybody. I'm honored to be here. As Brenda said, I'm Dr. Shannon McMann. I have been doing obesity medicine officially since fall of 2021. I started studying during COVID. They offered virtual training, which included over 60 hours of online modules, and then an additional 8 hours of board review. And then ongoing continued certification where you have to do articles with quizzes, so many per year to stay certified. And I am training the residents in lifestyle medicine. I have not yet sat for the boards. Maybe next year. It's been a little bit busy this year, but either way, I'm still doing the curriculum, and I find very, very valuable. And as we get into it, I can explain a little bit about what is obesity medicine and what is lifestyle medicine. But in general, you can ask questions. We'll go through the medications. We'll go through tips and tricks if you're having weight recurrence or plateaus. And I'm open book, whatever we want to talk about. I'm passionate about this because when I went into my surgery, I just went into it thinking I just want to lose weight. Wasn't thinking about anything else except I just want to lose weight. And then when it finally worked, I'm like, why, after all these decades of me trying every diet, why did surgery work? So then I went a deep dive into why is obesity a disease? And that's how I found out about obesity medicine, which I didn't even know was a thing until then. So that's my story.
I have to say too, obesity medicine doctors are sought out. Like it's definitely an incredible specialty. So you have bariatric surgery, and how does this fit obesity medicine? How does it fit under those categories? Like it's not just about bariatric surgery, it's about helping people who have issues with obesity, correct?
Correct. I mean, some people do prefer to specialize in bariatric surgery patients only, but I don't know. I do both medical management of anyone who suffers from overweight or obesity. They've been classified as diseases since around 2013, I believe. And then obesity medicine itself was established in around 2011. So all of this is, fairly new. But basically, obesity medicine specialists provide like a comprehensive, scientific, individualized approach to the treatment of obesity. Each patient requires individualized therapy because, as we can get into, there's different forms of obesity, or there's genetics, there's epigenetics, environment, behavioral. It's multifactorial. And it's not as simple as eat less, move more, like most people are probably told when they go to the doctor. And sadly, a lot of physicians still tell their patients, oh, you don't need surgery. You just need to put the fork down and go for a walk. And unfortunately, that's why there's so much stigma and bias, because it's, now obesity and overweight are viewed as, like a personality problem or a moral judgment instead of a disease. And so that's why there's difficulty in with coverage and access to the medications. And I think it was Dr. Eric Smith said about only 1% of people who qualify for bariatric surgery get offered surgery. So it's a lot of education that needs to happen in both the public and the medical community and the media. So I could go on. I don't know about that, but we'll move on.
It's important to know, though, because if there wasn't people out there like you that are doing the things that you're doing to kind of bring awareness to, obesity and what it really looks like I'm going to call it as a disease as well, those stigmas would continue, and insurance coverage and all of that, hopefully at some point is going to follow. I feel like not just for the surgeries themselves, and being more exclusive coverage for those people who don't always have access, because there are people who want to have bariatric surgery and can't because of certain types of insurance stipulations. But also the obesity medicine thing, so many medications now are not being covered. Do you have any updates on any of this? Because since you're so involved with all of that, do you have any updates on what that might look like in the future?
So right now there's several insurances as of January 1, or they're pulling all the anti-obesity medicines off the formulary, which, I'm probably, not supposed to say this, but to me, it's discrimination against a disease process. They wouldn't pull hypertension coverage or diabetes coverage or cancer coverage, but they're going to pull anti-obesity medication to treat those diseases. So the only glimmer of hope at the moment is there's in legislation, it's called the Treat and Reduce Obesity Act. And the goal is to improve awareness about the disease of obesity, to end stigma and bias, and to provide increased access to treatment. So, there's a lot of studies going on now with the medications, which, we can go into, but they've shown that these medications have been shown to reduce major adverse cardiac events, so to reduce risk of heart disease and heart attack. They've been shown to improve or reverse sleep apnea, Zepbound in particular, tirzepatide. They've been shown to reverse prediabetes or insulin resistance. So there's multiple benefits to them. It's not just about losing how many pounds you lose. It's improvement in your cholesterol, improvement in your blood pressure, improvement in your breathing, improvement in your joint pain and inflammation, decreasing your the adipose tissue or fat tissue around your organs. And there's also a push to reduce the shame and stigma that surrounds patients who suffer from overweight and obesity. We used to use in medicine, there's still providers that still use it as an adjective. It's not an adjective. You're a person who suffers from obesity. And they've also changed the coding and nomenclature. So briefly, if your BMI, it's by BMI cutoffs, but there's class 1, class 2, and class 3 obesity. We are trying to get away from using the words morbid obesity because that implies so much shame and stigma and negative connotation to it. So now we go through class 1, class 2, class 3 obesity based on BMI, But even based on BMI is being looked at, because BMI does not look at your body composition. We want to look at your muscle, your lean body mass, which is your muscle mass, your bone mass, your organs, and versus your visceral adiposity, which is the fat tissue on your organs, or your central adiposity, where you carry your weight matters as well. So you're going to see a push more to look at body shape and composition more than just body mass index, because you could be a bodybuilder and still have an elevated BMI, even though your percent body fat is very low and your muscle mass is very high. So, so as for coverage, the short version is, I'm hoping as more medications come out down the pipeline, the cost will improve. And I'm hoping if the Treat and Reduce Obesity Act gains coverage or gains more ground and pushes for more coverage, especially by government insurances like Medicare, Medicaid, or CMS, then that is what all the other insurances follow. So if we can get that to gain traction, then hopefully we'll see improvement. But there's also a new administration coming in that has some people, main people involved that are already talking negatively about the medication. So it's going to be a uphill battle, unfortunately.
So 2 questions. You mentioned something about something coming January, about some things being taken off the formulary.
Yeah, so I don't know all the insurances, but I know that there's several big insurance companies that starting in January 1st are no longer going to cover Wegovy, Zepbound, Saxenda, Contrave, Qsymia, all the branded ones. They basically, it says they exclude any anti-obesity medication. So that's a big problem, because a lot of my patients who are doing well on these medications are losing coverage. And unfortunately, it's even, hospital system insurances that has dropped coverage. So, there are cash pay options. They're just very costly. But it's things are moving in the wrong direction, unfortunately. But the companies, if you have commercial insurance, and your insurance does exclude it, you might be able to use the savings card and get it at a reduced cost, but it's still very expensive. And if people have specifics, I can give you the ideas of the cost. But yeah, so it's right now the outlook is not great, but there's a lot of like the Obesity Action Coalition has sample letters on their website that you can send to your insurance company or your employer, or your state representatives to try and raise awareness. So we have to all be our own advocates. But as of right now, there's more people pulling it than adding it. But the glimmer of hope that we got away from that, Medicare is considering covering semaglutide or Wegovy in patients who have overweight or obesity, not for weight management, but to reduce the major adverse cardiac events. So we may see coverage shift to, instead of being a weight-centric treatment, it's to reduce risk, or tirzepatide or Zepbound is in the studies with improving or reducing sleep apnea. So we may be able to see coverage if you have sleep apnea. You might be able to get those medications covered. There's another study with semaglutide or Wegovy about the incidence or quality of life and pain levels of people with knee arthritis who are on that medication. And that had very positive outcome in that study as well, where people with severe knee arthritis had less pain and improved quality of life after being on semaglutide for a year. So there is hope, because we're now looking at all the benefits of them, that maybe if they start seeing how many disease processes these can affect, that maybe they'll change their mind. And that, so you won't be getting it just for weight management. It'll be getting it to improve your sleep apnea, improve your diabetes, improve your heart disease risk, that kind of thing.
So I do have a question here, Dr. McMahon. It looks like Sarah asked, is there any risk using a compound pharmacy for GLP-1s?
Well, so compounded medications are not FDA approved, and none of the medications currently are available as generics. That being said, most of us providers care more about access than necessarily that. The only thing I would say is see where you're getting it from. There are different types of pharmacies, and off the top of my head, if I remember correctly, you want to pick a 503B pharmacy because they're at least FDA regulated. So what that means is they have to have the same active ingredient as the branded drug. So say you're getting compounded semaglutide, a 503B pharmacy, it has to have the same active ingredient as Wegovy or Ozempic. Whereas I have seen like some medical spas or different places have it like semaglutide mixed with B12. Well, that gives me concern because how much of it, how much variance is there between different places. So I would say if you're going to go uncompounded, go to do your homework on it. And, if you want to seek out an obesity medicine provider, you can go to the Obesity Medicine Association page, and there's a link where it says find providers in your area. And that will list anyone who's, either fellowship in obesity medicine or board certification in obesity medicine in your area. Because they would, not that primary care can't manage obesity. I would just say if you're concerned and you want to see, or you say your, primary care doctors are usually very busy and have short appointments, they might not have the time, whereas someone who's dedicated their practice to obesity medicine specifically may have, more longer appointments and more comprehensive care. Most of them have a center where they'll have a behavioral therapist, registered dietitian, a fitness expert. They might be linked to a bariatric surgeon so that you have, multifaceted treatment options. And I thought I saw a question pop up, but I don't see it now.
It looks like there's a couple.
Okay.
Somebody is actually thanking you too, because they said they have a friend who uses a compounding pharmacy. And actually, I use a GLP-1. It's prescribed through a provider, and mine's a compounded prescription through another pharmacy. And I've not really done any deep checking, but I do trust the provider that I use. I know them I feel like that I'm hoping they would only use, going to somebody replicable too. Would you say that that's something? Because usually I would think if you are a provider and you would want to trust what you're using too, I would think, correct?
Well, I mean, in theory, yes, but I also look at the cost versus how much success you're getting. Because I have seen some that are very overpriced, and I've had, patients go into these places and get them, and I'm like, fine, let's give it a try, but they're not losing weight on it. So that makes me think that it might not be strong, like the concentration might be off or the dosing might be different. But there is about 20% of people who do not respond to GLP-1s. They may not lose weight on them, about 1 in 5 patients. So there is, because of how complex the disease of obesity is, it may not be as simple as, healthy nutrition, increased physical activity, and a GLP-1. You might need other things. So
that's true, because like it's not always with even bariatric surgery. It's not just a one-stop fix all. Like there's so many different components, as you mentioned earlier, that go into what causes someone to have issues with obesity. There is another question here: is which obesity medicine is geared to cardiac incidents?
To reduce cardiac. So the one with the most data on reduction in major adverse cardiac events, or decreasing your risk of stroke or mini stroke or arterial disease, semaglutide at the highest dose of 2.4 milligrams, which the branded name is Wegovy. That one has the most data on that at the current time. I'm sure tirzepatide will come out with something because they're studying multiple things, but semaglutide is the second oldest one that's been out. We've been using these in the diabetes world for over 10 years. So in studying them in all these trials for safety, they actually saw people have less cardiac problems, because they're studying to make sure that wouldn't cause cardiac problems. Because back in the day, the oral weight loss medication, fen-phen, ended up giving people something called pulmonary hypertension, which is deadly. So that's why they have such rigorous studies. They have different phases. So phase 1 trial to phase whatever their endpoint is, they have to do rigorous studies before it becomes FDA approved and considered safe.
Any suggestions for somebody who might have been prescribed one of these drugs and maybe either because of supply and demand or maybe their insurance coverage benefits? What would you suggest to somebody who's wanting to get started? Elizabeth says, I was prescribed Wegovy back in June, and due to not having a supply, have not yet to receive the prescription. So do you have any suggestions with any of that?
So the good news is Wegovy, the supply has been much better. And same with Zepbound or tirzepatide. Both manufacturers have increased their production. And then tirzepatide or Mounjaro actually has vials that you can pay cash for through Lilly Direct Pharmaceuticals. Still costly, but a little less costly than buying the pens. But in general, the other things you can look at if you can't get it at a local pharmacy is Amazon Pharmacy, like another online pharmacy like Pharmacy Advantage. Sometimes those the mail away or the bigger companies may have improved access, but sometimes you just have to kind of call around and look at stock. But right now, it seems like the Wegovy, the lower doses sometimes are still a little difficult, but the higher doses of 1.7 and 2.4 are generally more available. Whereas Zepbound or tirzepatide, it might be the opposite. The lower doses are available, but then the higher doses might be tougher to find, especially the 12.5 and the 15, I think has been an issue in the area. If there's a will, there's a way, as I say. Like if I can help you get something, I will. And that's, you want to find a provider that is invested in treating the whole person and wants you to succeed in your weight management journey for your health.
There's some more great questions coming in too. One of them, Heidi says, how long is it safe to take a GLP-1? Are there any long-term effects? And actually bridging that question with something else too is, this is something that you probably are commonly working with patients. So you've probably seen patients that's been on these medications for long periods of time. So this is you're probably a great person to ask this question to.
So the medicines, so let's just back up a little bit. So Wegovy is semaglutide. In the diabetes world, it's Ozempic or injection, or Rybelsus is oral. So the next one that's, the newest one is Zepbound or tirzepatide. In the diabetes world, that's known as Mounjaro. And then the older one that's a daily injection is Saxenda, which is liraglutide, which in the diabetes world is Victoza. So in the weight loss world, if they're FDA approved for weight management, it's for chronic weight management, meaning you're supposed to take them indefinitely. Do you need to stay on the full therapeutic dose? Maybe not. But unfortunately, there was just a study with tirzepatide or Zepbound that I want to say, like, they studied people for 88 weeks, but halfway through they branched people from Zepbound to placebo. And unfortunately, the Zepbound group continued to lose weight and 80% of them kept it off, whereas the placebo group had significant weight gain and then only ended up with a 9% total body loss, whereas the other group had 25% total body loss. So there are incidences where you can stop it and not have weight recurrence, but obesity is chronic, relapsing, remitting. It's not cure. There's no cure. There's tools. So I tell people, yeah, I can get you the link of the study. It's fairly new, like literally, I think just came out. I want to say it's Surmount 4, but we'll put it in the show notes. We'll get Brenda the information. I just read so many studies in the last 2 weeks preparing for this. They're all kind of flying through my brain right now. But so let's talk about dosing and then we'll circle back. So Wegovy is approved at 1.7 milligrams and 2.4 milligrams weekly for chronic weight management. The other doses are considered step doses or titration doses. So sometimes you have a hard time, say you're doing well at 1 milligram, the insurance may give you static because it's not approved for long-term weight management except at the 1.7 and the 2.4 milligram dose. For Zepbound or tirzepatide, the dosing approved for chronic weight management is the 10 and 15 primarily, but some insurances will pay for the 5 milligram. Basically, when we're dosing these or managing these, we look at how quickly you're losing weight, because we don't want you to lose too quickly, because that means you're losing lean body mass. So in general, we still want you to lose about either 0.5 to 1% of your total body weight per week, and no more than around 6% per month. And you have to make sure you're getting your water goals and your protein goals, and resistance training and physical activity. Otherwise, you can lose up to 10% of your muscle mass over the first year, which is equal to like 20 years of muscle mass loss. So this is, people in the media, they're calling it Ozempic face or Ozempic butt, but basically what it means is rapid weight loss, muscle loss, so that you're getting, all these side effects. And with rapid weight loss, you will lose hair, it's normal to lose some lean body mass, but you do not want to get to the point where it slows your metabolism down. Saxenda, the maintenance dose is 3 milligrams a day, once a day injection. And the compounded, it depends, but it's generally the same rule. You'll stay on the dose. If you're losing too much too fast, then you could back down. Some people also, when they hit to their goal weight or body composition, they will stretch out their injections and take them every 10 days instead of every 7. There's no evidence to support that, but if it's working for that person, I have no problem doing that, because it is costly, and if they can spread it out, then that might be great. And some people can even get away with taking it like every 2 weeks and still maintain. But most people, when they stop a dose, like say there's a medication lapse, they're like, the food noise is back, I'm hungry again, so most people do require lifelong treatment. So when you look at the disease of obesity, as we said, there's no cure. So you look at the treatments. The most effective treatment to reduce body weight and or reverse obesity, or put it into remission, so to speak, is still bariatric surgery. But they're also studying using these medications, the GLP-1 receptor agonists, in conjunction with bariatric surgery. So put them on pre-op to get that, some weight loss, like a liver shrinking diet type thing. And then at, 18 months to 24 months, when your hormones start to go back to normal after having bariatric surgery, getting you on these medications then before you get significant weight recurrence. So it's not an and or kind of thing. It's basically, we have to throw whatever medical tools we have at the disease to keep it in control. And some patients require, multimodal therapy, and some don't. So it's got to be individualized, basically.
So actually, I think you've answered, there's 2 questions that are kind of combined that kind of you touched on. Sura says, not sure. Can you take a GLP-1 after weight loss surgery, stall after bariatric surgery, which you mentioned that is sometimes indicated.
Yeah.
And then the other one is like, would you do it before having surgery? Would it be beneficial to take like Wegovy and then do bariatric surgery or revision of gastric bypass?
So it depends on why you're getting, a lot of steps here. So if you're getting revisional surgery, it depends on what kind of symptoms or what kind of, are you getting a revision for weight recurrence? Or are you getting a revision because of severe heartburn? If it's for heartburn, the GLP-1s may not be the best choice, because one of the side effects can be increased heartburn, bloating, or belching. But that being said, doesn't mean you couldn't try it. But if you're getting revision for, reflux or heartburn, that might not be the best idea for you. After bariatric surgery, as long as you have no history of like bowel obstructions or anything like that, you want to wait till probably at least a year out, I think is most people's rule of thumb. But there's nothing written in stone. At 6 months, if you had a prolonged plateau and your BMI is, you're not heading in the right direction, or but your goals aren't being met despite doing all the things you're supposed to be doing along in conjunction with that, I don't think anyone would say no, there's a hard stop until you're a certain amount out. But I would probably say at least 6 months out would be probably my threshold. But most likely, most people would probably want you to wait a year, because it's normal to have stalls. it's not normal to lose weight. Basically, your body wants you to keep the weight on because it sees it as a protection. It seems like, if my partner will say, think of, back in the day, if you're a peasant, the ones that survived were the ones that had excess weight, or ectomorphs or endomorphs, those kind of things. Different phenotypes had different survival. So basically, your body sees the extra adipose tissue as storage for survival. But the problem is as our society is not having to hunt for food and walk everywhere and things like that, our bodies did not adapt. They still want to store calories for emergencies. So it's hard work, basically, to get your body to reverse that protective mechanism. And sometimes it takes multiple different kinds of therapy.
I have another question. Before we get to that one, it's kind of going back to the one about using it lifelong, like using some of these drugs lifelong. What would your suggestion be? Have you had people successfully come off, like somebody that's been on these medications for a longer period of time and then been able to taper off of them for
Sadly,
weight loss?
no, most of my people on them, they might have been off for a time, but then they see the weight start to creep up and they want to go back on it. So I didn't also get to the long-term risks. So there really is no known risk for long-term use, except, cost. They've actually shown multiple studies. I mean, there's so many studies going on right now, but there's a study that shows that these medications may slow the onset of dementia, but it's probably just how they're changing your physiology. We already talked about that they reduce your risk of, and semaglutide, reduces your risk of heart attack and stroke. Losing weight in general reduces your risk of cancer. Bariatric surgery actually reduces your risk of certain types of cancer by up to 50%, they found. So treating the disease process has multiple benefits. As I said, these medications have been out for beyond 10 years now. And, there are rare people that may have, side effects, but they're in general very well tolerated. Mostly, we dose them slowly up to get to the therapeutic doses to minimize the nausea, bloating, belching, diarrhea, constipation. The reason not to go on them, as I said, would be history of bowel obstruction, or something where, like, serious digestive issues. You would definitely need to clear it with your gastroenterologist or your doctor. If you had a history of pancreatitis, which is inflammation of your pancreas, and you don't know why, it's a risk, because there is a risk of pancreatitis, but it's usually more in the setting of using alcohol on these medications. But there are some incidences of pancreatitis, but most likely it's related to other things. If you have a gallbladder that might be on its way out, these medications may accelerate that because it changes your digestion. So I wanted to go through each med and the mechanism of action, all the things, and we're kind of jumping around. So basically, the GLP-1 receptor agonist, they work by keeping your own body's GLP-1, which is a hormone that has multiple receptors or actions in your body. So they basically work on the part of your brain called the hypothalamus to reduce appetite, turn off that food noise some people talk about. They basically slow down gastric emptying, meaning they'll stay full, get full faster, stay full longer. And they also make your pancreas make more insulin and make your body become more sensitive to your own insulin, and make less of your own natural sugar called glucagon. So they work multiple different ways. And because they work on the part of the brain, that hypothalamus area where the hunger centers tend they're also seeing people have improved mood on them, less addiction, like less alcohol cravings, less food cravings. So there is definitely a gut-brain connection that these medications, they work multiple different ways. So I think I saw pop up a question, and that I was going to get to that. So you might read about risk of thyroid carcinoma. So in animal models, I think primarily rats, they did see an increase in something very rare called medullary thyroid carcinoma. If I recall correctly, humans don't have GLP-1 receptors in their thyroids, but the animal models do, the rats do. So is it a risk? Possibly. So you have to look at risk benefit. There's also a rare syndrome called multiple endocrine neoplasia type 2 or MEN2 syndrome, also seen in animal models, not in human models as of yet. So we go through all this. When someone comes to me and they want to go on this medication, I go through all this with them. Do you have any history of bowel obstruction? Do you have any history of pancreatitis? Do you have your gallbladder? Does it bother you? Do you have any digestive issues? Do you have any family history of the medullary or thyroid carcinoma or MEN2 syndrome? You don't want to take them if there's any chance of pregnancy or lactation, those kind of things. So each individual patient, you look at the risk-benefit ratio. And then aside from the GLP-1s, Zepbound is tirzepatide, which is a GLP-1, and GIP, which is a hormone with like 25 letters in each word. So it has two mechanisms of action, so it's a little stronger. So with Zepbound for a year, you can lose up to about 20 to 25% of your total body weight. Wegovy or semaglutide, about 15% of your total body weight at a year. And Saxenda or liraglutide is about 5 to 8%, 8 to 10%, kind of depending on where you look. And then there's two other oral medications that are FDA approved for weight management. One is called Qsymia, which is phentermine and topiramate, and it works as a stimulant, meaning it suppresses appetite and also may change cravings or break that food reward cycle. And then there's Contrave, which is bupropion and naltrexone. Bupropion is actually an antidepressant, also known as Wellbutrin, but it works because it increases your dopamine and norepinephrine levels by blocking the receptors, so it keeps it around longer. So because you have more dopamine, you might not get as big of dopamine release when you have sweets or cravings or whatnot. And same with naltrexone. They use naltrexone for people who are trying to stay off alcohol or opioids because it blocks opioid receptors, which are, that mind-body connection of, the addiction. And then generic medications, you can use generic phentermine for people who have trouble with appetite or maybe slow metabolism. And then there's some much older ones like diethylpropion that also is like phentermine. And then there's orlistat, which used to be called Xenical or Ally, which basically blocks your body from absorbing the fat in your diet. The downside to that is if you eat too many fat grams, you could have loss of bowel function or loss of bowel control and like oily stool leakage. So, the generic ones aren't great, but in a pinch, we can be creative. Sometimes you'll see metformin used. Metformin is a medication seen used in diabetes world, but if you're insulin resistant, it may help you lose weight. And they also think it helps keep naturally helps keep your own GLP-1 up by changing your gut microbiome or the balance of healthy to unhealthy bacteria. So those are the main medications. You'll see also there's some of the like Plenity you may have seen, where it's basically a capsule you take and it expands in your stomach, and it automatically goes away after like 6 months. Or there's Obera, which is a balloon that a surgeon can place, or and it basically takes up space in your stomach, along with you eating a healthy diet and healthy amount of physical activity can lose weight. But again, once they're gone, most people struggle because your body goes back to wanting to preserve your set point, so to speak, or keep your weight at a certain level.
There was just a comment too about this being recorded and sending it out. Anybody will be able to access this on replay. We have an on-demand replay. So if you click on the same link you used to register, you'll have it. And usually I keep it active till the end of the month, but we're at the end of the month. I'm going to keep it active for 30 days. We also do put these recordings on our YouTube channel, the ProCare Health YouTube channel. And we also have it added to our podcast, which is called Very Connected. So you'll be able to listen to the audio. So on demand, using the link that you used to register, the replays will also be available starting next Tuesday, and that'll be on our YouTube and on our Very Connected podcast. I want to say too, there was a question about the studies that you mentioned. What would you recommend? I'm sure that you've read so many, it's probably going to be hard to access and name one single study that you've mentioned, but how can people access a lot of this literature? Where do you go to find reliable information that is
No,
out there?
the problem is even for me, there's so much jargon and statistics that they're difficult to read. So I would look through, the Obesity Action Coalition has some great resources. The CDC website, reputable sources. I'll make you a list to post of both the scientific, painfully boring to read, but excellent once you learn about it. And some other resources. I would give my patients a list of my favorite podcasts because since I'm a patient, especially during COVID, I would take walks and listen to podcasts. I don't know, is it okay to reference other groups?
Oh yeah, absolutely. Go right ahead.
I think they're all affiliates anyway.
Yeah.
So the OSLP girls, our Sleeve Life podcasts, have some great podcasts. Connie Stapleton has an excellent podcast and a program called Bariatric. Bariation. That's how I found out that obesity was a disease, not from medical school, but from a podcast on Berberine with Dr. Eric Smith. And then Dr. Eric Smith they have their own podcast now. There's a couple different ones. There's Transforming Your Life, I think, with Teresa and Tanya. And their new one is called Pop Culture Podcast, I think. There's Active Bariatrics with Kim Tirapelli. I mean, I could go on and on. There's so many great podcasts. I find I like to walk and learn, or walk in if I need mental health support. I'll go look for what to do when you're struggling with getting back on track, what to do when you're struggling with mindset. So I like Mel Robbins' podcast, but I have a list. I literally give my patients with my favorite podcasts, so I can include that. I'll make you a document that has the websites I refer to, the podcasts I refer to, and also a link to the scientific articles. Oh, I can't hear you all of a sudden, Brenda.
I had myself muted because I was typing in as you was talking because I wanted to type in some of the ones that you mentioned for people. A lot of these, I think all of the ones you've mentioned so far, except for Transforming Teresa, I've met Teresa Parrott and her colleague, and I'm trying to remember her friend that she was always
Tanya.
with her. Yeah,
Tanya.
Tanya. I've met them girls at multiple events, and they're a lot of fun. They both had a significant amount of weight loss and talk about their own journeys on social media. But as you said, they also have other ways that they share it. And those are all great. I mean, they're all wonderful ways to access. There's so many ways of getting support out there, guys. It's appreciated. And it's interesting too, coming from a lot of some of these people that are here on this platform today are actually professionals as well. And just as yourself, even if you're a professional and you're in this industry and you're out there, I can say for myself, because I also have weight loss surgery, many of you are aware of that. But being in community, we all learn from each other. Like you learn, it sounds like you've learned just by listening to, even though you're part of that obesity medicine, you're also being in these communities is also super helpful too.
Well, yeah, I mean, we're all patients lifelong. As much as we want to get to our goal weight and be done. It's not a sprint; it's a marathon. So we all struggle with the same things: mindset, movement, dietary changes, life stress. So it's important to lean on your community and work on your mindset. I mean, I'm almost 5 years out and I'm still battling, negative mindset. If I don't do everything, we all are guilty of that all or nothing thinking. If I don't do everything perfect, I failed. So I think really learning to think positively, say what you're grateful for, have affirmations, look at your wins, and lean on your community. So there's so many different resources, and most of them are free. Some are paid for, but in general, it's important to work on all aspects of your health, not just get to a certain number on the scale, but is your brain healthy? Are your relationships healthy? Are you using your, keeping your muscle mass and your body fat percentage at healthy levels? So it's not a simple journey. It's not the easy way out. I'm sure we have all heard that. And people don't have filters. They think they can say what they want about your weight loss journey, especially if you have setbacks. They'll say, "I told you so," because so and so, my aunt, second cousin's brother, had weight loss surgery and he gained all his weight back. So I think that's why I'm so passionate about it, because we've all been categorized as basically set up for failure our whole lives with weight loss, fad diets and different things. That there's a lot of education and healing that needs to go on in both your whole life, your whole person, not just your stomach. The surgery and medications may work on your appetite or your stomach, but you have to do the mindset work in the body composition, making sure you're getting your protein and your vitamins, and getting your blood work checked if you're a bariatric patient. I'm a big proponent of that, because if you don't take your supplements, that's another whole podcast. You can get some very severe deficiencies. It can affect your whole body. In women in particular, you can get osteoporosis if you don't take your calcium and your vitamin D and do weight-bearing exercise. So, that might be a thing we could summarize at the end. Like, what should you ask your doctor for once a year after you've had bariatric surgery? Because until I went through this training, I didn't know how to take care of post-op bariatric patients. So we could definitely go through. But, when you have weight recurrence, it's the norm, it's not the exception. The average, usually after you get to your lowest weight, it's normal to rebound up about 10 to 15% because your body wants to live at a certain weight. And I saw a little thing pop up. You don't get weight recurrence just because of not exercising. Why physical activity is important and why protein is so important and why your vitamins and supplements are so important is to keep your body composition healthy. You've got to keep your muscle mass up and your bone mass up, or your metabolism slows down and your bone health goes down. So if you're experiencing weight recurrence, it's not your fault. It's probably from years of yo-yo dieting, and you probably have something called sarcopenia or low muscle mass, which slows your metabolism down. So there's actually some really interesting studies by Dr. Acosta out of Mayo Clinic, where he goes through what's called obesity phenotypes. So some people might have what's called hungry brain, meaning you have food noise and you think about food, and when you eat, you still don't feel satisfied. You may have something called hungry stomach, where your stomach empties too rapidly, and so you're hungrier again right after you eat. And then there's emotional or stress eating, which that usually is due to unresolved trauma or guilt or shame or various reasons, which you need to work on, CBT. And then there's the final type, which what got me into this is slow metabolism or slow burners because of low muscle mass. And so he has an article, which I can include in their link, that talks about tailoring your nutrition and physical activity plan based on what type of obesity you may have. He actually has a company called Phenomics, where I think they can actually test you for some of the genetic markers or do studies to figure out where you are at. And then I saw something pop up, but what was the other thing I was going to say? I saw the question. Maybe look and see what the question was. Someone said I'm not using. There's a few questions. So one was, is Plenity been studied in weight loss surgery patients? I can't say I think it's a good idea because we all have our stomach anatomy has been changed. So I would say you might be able to use it with the sleeve, but I don't think it would be worth the risk. I definitely wouldn't use it with a gastric bypass because of how small the pouch is. So that's probably, I don't know that there's studies, but I personally wouldn't prescribe it to a post bariatric patient without conferring with a surgeon. And then someone said they weren't losing on Mounjaro. So my questions would be, what strength are you on? Are you on it for diabetes? Are you on it for weight management? Because Mounjaro is for type 2 diabetes, FDA approved for type 2 diabetes. Zepbound is FDA approved for weight management. in the studies in general, patients with type 2 diabetes tend to lose less weight on the GLP-1s than patients who don't. So those would be the things I would look at. If you're not responding to Mounjaro, you could try Wegovy or semaglutide, or I would say add what we call adjunctive therapy to the Mounjaro. So if you're on Mounjaro and you're still having food noise or cravings, or maybe you need help with your metabolism, tailoring your macros, tailoring what kind of physical activity you're doing, and or adding a medication like Contrave, Qsymia, or metformin to the Mounjaro to give you a boost in that direction. Someone said, have you done any studies on Berberine? I don't, off the top of my head, I really don't look at a lot of the herbal medications because the long-term studies haven't really panned out. I mean, I actually have seen Berberine used for migraine reduction. It causes a lot of burping and belching, so I can't say it would be probably good for a post-sleep patient, but I can get back to you on that. I haven't seen any hard data on Berberine.
Dr. McMahon, how about muscle mass? So you mentioned something about, BMI tests or BMI ratings aren't always they're not 100% like the whole picture, because you're only showing the weight, you're not showing muscle mass. What is the question is there a way to test muscle mass? And then also my question is what is a good number for percent of muscle? Or do you know that?
I don't know the hard facts. It's more important about keep maintaining your lean body mass and reducing your visceral adiposity or your percent body fat. So there's a couple ways. Ideally, every bariatric patient before surgery, which it doesn't happen more than it happens, should have a pre-operative body composition analysis. So there's special fancy scales that some centers have, like InBody or Sika. There's professional ones. The gold standard is actually something called a bone densitometry or DEXA scan, but very expensive. Not a lot of studies have it. Some places have something called bod pods where you get in this little machine and they measure your composition that way. What I have my patients do until I have one of the real, medical grade body composition analyzers, there's some fairly affordable scales on Amazon made by Renpho, RENPHO. They work by something called bioimpedance. So you want to make sure you're hydrated. It's first thing in the morning. You step on barefoot and make sure the surface of the scale is clean. And it gives you a rough estimate of your body composition. It'll tell you about total body water, bone mass, visceral adiposity, percent body fat, and muscle mass, and different kinds of skeletal. Will tell you skeletal muscle versus your total, all your muscle. And you have to look at it over time. So don't, panic if it's not great after 1 week. I would look at it like once a month and compare to the last month, especially if you're on your weight management journey. But in general, to maintain muscle mass, the hard and fast tips and tricks is to make sure you're getting at least for women 60 to 80 grams of protein a day, and men 80 to 100. If you're trying to build muscle, it's even more than that. This is like another whole thing, but we can go over it briefly. You want to make sure you're getting resistance exercise. So ideally, whole body resistance exercise twice a week. And that means either light weights, resistance bands, body weight strength, yoga, Pilates, Tai Chi, that kind of thing. Walking with weights on, or something called rucking. But it's important to get that resistance training. And it doesn't have to be fancy. I tell my patients to start with, try and get 10,000 steps a day, or at least, more steps than you're getting currently. Try and do 10 minutes of, resistance training 2 or 3 times a week. I think it's variation where they say, actually even Peloton is another one that says something is better than nothing. So we all think, oh, I didn't go to the gym every day this week. I no. If you have lunch break, like I literally went outside in the freezing cold and walked 2 miles at lunch because, it's been shown that walking in fresh air elevates your mood, reduces anxiety and stress. It's good for your bones and muscles. It's good for your heart and lung health. But you do want to do, as I said, some resistance type training to keep your muscles and bones healthy. Using resistance type exercise also helps your body's sensitivity to your own insulin and helps your lipid panel, your cholesterol panel. So lots of benefits. I kind of got off on a tangent on that, but for body composition in general, you can look for a place that has the body composition analyzer. There's a couple apps, I haven't had time to explore them, that you can do it with your smartphone. I don't know how accurate they are, but I know that there's been some exhibitors that we just were at the conference about those. One was called ZoFit, and I can't remember the other one right now, but again, we can provide links. I give these to all my weight management patients. But if you want to track at home, the Renpho scale, there's multiple different types, but the lowest price one I want to say is around $30-ish. But basically, there was a YouTube review where the guy looked at the bone density, bone densimetry or DEXA, one of the really expensive Withings scales versus Renpho. And over time, the Renpho had just as good linear data as the Withings scale. It wasn't exactly perfect. I want to say it was like something like 10 to 14% off, but it was still linear. So meaning for you to follow it over 5 years, it was still adequate to track your progress. And so I tell people, I use one at home myself, but it's hard not to look at all your numbers. So like we all get so upset, I guilty also, you weigh yourself in the morning and it's up 2 pounds from yesterday. Well, you have to eat 3,500 extra calories to gain 1 pound. So your weight is going to fluctuate based on your water weight, when you've gone to the bathroom last, how much sodium you've eaten, that kind of thing. So it's important to look at this number on the scale as a data point. I always get on my soapbox. It's not a measure of your worth or your success. It's a data point. You want to look at, do you have more energy? Are your clothes fitting better? Look at your waist circumference, look at your neck circumference and your arms and your legs. Take measurements, because if you're exercising, you're going to lose inches before you see the number on the scale. So we could talk about that all day. We can do another one that's specifically on muscle mass and body composition, because that's one of my passions. I saw someone say, another question just popped up. Well, I lost it. What are your thoughts about protein? I just found out how to open up all of the questions. So what are your thoughts on supplementing your protein intake with protein shakes? Ideally, you want to get your nutrients through whole foods. But if you're struggling to meet your protein goals, I'd rather you supplement at least, maybe 1 shake a day, but those aren't, and make sure it is a true whey protein or soy protein. Collagen protein isn't adequate. That just helps your skin and nails. So look at the type of protein. And I think Active Bariatric, she has a whole podcast on that. I can put that in the links. I personally am not a breakfast eater, so I will drink a protein shake in the morning for breakfast most days. Sometimes at lunch, if I'm on a run, same thing, I might grab a protein bar, but eat fruit or something like that. I saw someone said my Renpho was only 3% off from the DEXA for body mass, and it was $30, and the DEXA was 100. Yeah. So that's what I said. They don't want, the people trying to make money off of us, they don't want you to know that. So I did a deep dive, and that's how I found a YouTube video, and how I found out about Renpho is because I was trying to decide what body composition scale I wanted, because part of me wanted to go get the InBody for, $1 zillion, and then I saw that the reviews with the Renpho are, so I started there. Pea protein, I'd have to look into that, but I think that's okay. Yeah, collagen is more as a supplement to use for hair, skin, and nails. But if you're doing that on top of regular calories, so sadly, I just heard on a podcast this week that even if you do 10 or 20 extra calories above what you're burning a day, you're going to gain like 10 pounds in a year. So it doesn't take a lot. So you have to make sure you're, logging your food and eating your fiber and protein first before you're eating, simple carbs. Reduce your processed foods. Make sure you're physically active, because unfortunately, you can look at something called your resting metabolic rate, or your what your metabolism looks like. And for most of us, especially after menopause, your basal metabolic rate may only be like 1,200 calories. So if you eat 1,210 calories, you're going to gain weight unless you're doing a lot of physical activity. So it's very difficult. Your body basically resists you from losing weight. And then, especially as females or as chronic dieters, we've yo-yo dieted and most likely have, over the years damaged our metabolism by losing muscle instead of, along with, body fat percentage.
So many great comments here and questions and all of that. And I want to kind of I know we're getting right here, we're right at 2 o'clock, and I want to be really good with your time because I know you had a packed schedule. So how can people get a hold of you, Dr. McMann, if they would like to? For one thing, we will put out at some point. It probably is going to be next week by the time I get Dr. McMahon's notes and combine those, but we'll put out something if you've registered for this live event. And I'll try to have a link available for her notes for maybe even those on replay. Try to figure a way to do that. Probably on our website, we have a support group handouts page, so maybe even be able to put that on there. How can they get a hold of you? What's the best way, or do you have any?
So I don't have any professional social media. I have personal ones, and they're kind of on lockdown because I don't I don't like to argue with people on the internet. So I just have very close groups. So on Instagram, if your handle says that you're a weight loss patient, a weight loss surgery, or weight loss journey patient, I usually accept those. So my Instagram is at DRSM for Dr. Shannon McMann 718. I'm more active on there than anyone else. You can at me in the Berry Connected group. I'm there. So, and then we can certainly, I also am affiliated with Berry Nation. So I have a few podcasts with them. And if you're a member of Berry Nation, you can send me a direct message on their app. But I'm happy to help, but I also have a full-time job. So if it takes me a little bit to get back to you, reach out to Brenda and she can get a hold of me. So I'm like I said, I love doing things to give back to the community. I'm passionate about helping people on their weight management journey. And it's been a pleasure doing this podcast / Zoom webinar.
Yes, thank you so much. Thank you so much. And I just wanted to, do you have a closing thought that you'd like to say?
So I think I said kind of, all over the place, but number one, be kind to yourself. Work on having positive inner narrative, because if you have negative inner narrative, that is going to only impede your success. So look at your wins, go listen to a podcast, go for a walk, do something that helps give you joy. It's hard work being a weight management patient. There's ups and there's downs. It's frustrating. It's exhausting. So basically, give yourself grace. Don't have all or nothing thinking. Try and write down what you're doing right and what you could do better. Don't wait till Monday to start. If you have a bad meal, start to try and do better at the next meal. I would just say small positive changes make a big difference over time, is what I tell my patients. So anything you're doing that's going in the forward direction is a bonus. If you're not perfect, no one is. So that's my big lecture to most of my patients and bariatric friends.
It's so true. I know for myself, like this last year, I kind of like for a lot of these people that are been on these calls, they probably heard me say this. Like I really just kind of hungered down and did a lot of different things to try to take back off any regain that I had gained. And for me, it was going at it in so many different directions. It was, for one thing, the semaglutide, but also hormone replacement. It was about really investing the time in myself. I mean, I've always been like interested in personal development. But I will say that this last year, I dedicated each day, I take 30 minutes to a couple hours of personal development of some sort, because you guys, where your mind is, your body will go. I mean, our bodies are just this miraculous thing. So it is super important what you're saying about that. It's coming at it in so many different directions, your nutrition, your vitamins, your everything. So
Yeah, I mean, I tell people, the health wise, I can't emphasize get your water, get your protein, get your fiber, and take your bariatric specific multivitamins and calcium supplements. Because if you're not getting the right nutrients, your body is going to fight you that much more. But even if you're doing all the right things and you don't do the head work, like Laura Graybow says, or Connie Stapleton, you have to do the work. Because a lot of times, most of us ended up turning to food for comfort or to celebrate or to, whatever is going on in your life. All it takes is a little trauma or a setback to get you going in the wrong direction. No matter what you see online, everyone has setbacks. I would say majority of us had weight recurrence. And once you're after a certain age, when you get the weight recurrence, I mean, I can't get the same 10 pounds off. And it's not about the number on the scale. It's about how your clothes fit and how you feel. And because when you're in menopausal or postmenopausal time, you get all that central weight gain. So it makes you feel like bloated all the time. So it's about more than just how we look. You have to be how you feel, but part of how you feel is how you talk to yourself and how you look at others. So working on yourself, I just heard a quote about this, by working on yourself, you're actually giving back to the community, because if you fill your cup, you're going to be more empathetic to the people around you. So we are all too hard on ourselves. We're all our own worst critics, and that is only hurting ourselves and probably making us grumpy to all the people around us.
I am. And I also want to just say, if it's okay, I'm going to do a little shout out to our sponsor, which is ProCare Health. Most of you guys who have been with us have been aware of our ProCare Health, our sponsor. And I just want to say, if you want to go out and check out anything ProCare, it's procarenow.com. Again, procarenow.com under ProCare Health. And be watching. There is some huge, and I'm going to underline huge, our biggest savings of the year are coming up Black Friday through Cyber Monday, sales on, I mean, all different kinds of products. And some big freebies are going to be thrown in. So be watching for that. That will start on Black Friday and run through Cyber Monday. I also want to say, when you go to the ProCare page, there's a tab called Very Connected. If you go and click on that tab, what you're going to find is all of our events that have for the month. And so you'll see Dr. Shannon McMahon's link. It takes it a second here sometimes to pop up. You'll see her event. You can click on that to watch the replay. I'll try to keep that open for 30 days. Again, if you can't watch it there, we will be adding it on our YouTube channel, the ProCare Health Vitamin and Supplements ProCare channel. And so was that there. We have over 400 and looks like 430 videos now on there. If you subscribe, there should be a subscribe button. Subscribe and you'll get notifications when new events are added, including her event, which will be added next Tuesday. All different kinds of stuff on there for you to access and love. And then we talked about the Very Connected page. So if you go to Facebook, when you go there, you can actually find the link for our Facebook page, Very Connected. We have a page and then a group. A group is where you can ask questions and kind of intermingle. And one is called Very Connect, one's called Very Connected. The page is Very Connect and the group is Very Connected. So join there, be a part of that. You can also interact with Dr. McMann there. And also just want to say too, one thing I'm going to be doing coming in January is a little class that I'm going to be offering for 12 weeks. It is called Mind, Body, Soul. And I will put the link here in
Brenda, can I just
class. Yes.
Sorry, I'm in Barry Connected. My Facebook handle is SHAN, Shan, and then NIC, capital NIC. So, as I said, I had some internet bullies, so I made everything private and changed all my names on social media. If you're a Peloton person, I'm at Shan, SHAN, Mac, MAC 718. So I'll give her all of these. It's Shan space Nick. There's a space in between.
Oh, there's a space.
Shan is my first name and Nick is my last name on there. Because like I said, I put everything on lockdown because it just was tired of, I needed an internet break. And I just wanted to also shout out to ProCare. ProCare, they are, I've tried all of the vitamins, and they are by far my favorite. I love the Orange Grove capsule. It's very easy to swallow. It smells good. It doesn't give an aftertaste. And their calcium chews are by far the best. And they also have probiotics in their calcium chews, which I think is amazing. The salted caramel is great. Obviously, the dark chocolate one is excellent, and I love the lemon and the cinnamon roll, like and the dinner mint. There's so many different ones. So great products, obviously great people. Brenda and her team are always so friendly, and when I met them in person, it was like we known each other for 10 or 15 years, both at ASMBS and at Bariatric Retreat. But they're most economical. They'll deliver them to your home. And there's good customer service. So I can't say enough good things about them. So it's been a pleasure.
Yes.
Again, I'll get you all the information we talked about, and we'll have to do this again sometime.
I would love that. I would love that so much. Well, I will be sending you a message after this. And I want to thank each and every one of you for taking the time out for yourself today to learn more about this and how to support yourself. And thank you, Dr. McMann. So appreciated from the bottom of my heart, sharing your knowledge. Each of you have a wonderful Thanksgiving. And if you're listening to the replay at a later time, just happy holidays all together. Happy New Year. We're getting ready to start 2025 too as well. So thank you and take care.